there is a lot of advancements and a lot of new therapies that have been approved recently, as early as this week. So we have a lot of options for these patients, and we can go ahead and get started. So, um, a few slides about the disease. There is still a great unmet need. There's still, about 9,000 people die every year from metastatic melanoma. It is, you can see where the United States incidence and mortality is. A lot of these patients are diagnosed early, but then, some around 5% have metastatic disease at diagnosis. And in the old days, we really didn't have many options to prolong survival, but now we do, and that's what we will be talking about. This slide really talks about the staging of the disease. This is the newest, form of staging that was created. We get involved in medical oncology for lymph node positive disease. So you can think about stage 3 and up, and the differences between 3A, B, and C, depending if you have the number of lymph nodes, or you have ulcerations, or if you have satellite lesions, etc., and stage 4 disease. So sometimes we may get involved earlier for T4 lesions that have 4 millimeter invasion or not. There's some data in the adjuvant setting for treating these patients. But usually not that often that we do make these recommendations. It is important to note that really the number one um, um, path to cure is to have an adequate surgery, and we are blessed here at Mount Carmel that we have very good surgeons that really can help us out. It's important to note also that even for stage 4 patients, surgery does have a role. And if you can actually resect all disease, it is preferable to render the patient NED through that uh, with complete surgical resection. This slide shows the survival rates and the incidence rates. You can see on that table the stage at diagnosis, localized versus distant, and then the 5-year survival rates. And if you look at the x-axis here for the survival rates, you can see that this goes for years, and then that curve, even for stage 1 patients, can still go down over many years. So melanoma is one of those diseases that is known that can still metastasize or recur years later. Now this curve is actually survival for all causes, but then we do know that patients with early stage disease can still reoccur many years later, which is an interesting fact because the patient that does reoccur 10 years later, this patient had metastatic disease from day one, right? But then, and so that speaks really about the melanoma and the immune system, and how basically that has a great role in keeping disease in check. So, and the other fact that we know that even stage 4 patients, some of them that do have a long-term overall survival. I think this is listed as 16% here. So some people with metastatic disease still survive a long time, which basically also speaks to this disease and its immune system, the role of the immune system in keeping the disease in check. So I'm just going to present one slide on the adjuvant treatment because, really we're talking about the new therapies of this disease. And then recently a trial was presented or published by the EORTC, the European group, using ipilimumab, which we will talk a little bit more later on in the adjuvant setting. We do know that there is a role for adjuvant therapy with high-dose interferon that goes for a whole year. Many physicians don't like that because patients cannot tolerate it. It's usually offered to patients that are younger, And it is really not been shown to prolong survival. That's why physicians don't really like it. And what it does, it actually delays disease reoccurrence, so it does have a disease-free survival benefit. So interferon is the basis for adjuvant therapy as of uh, maybe 2 or 3 weeks ago, when ipilimumab, it's a CTLA for antibody that was recently approved for the adjuvant treatment. And this is usually given at a dose of 10 milligram per kilo once a week for 4 weeks, but then patients stay on this adjuvant therapy every 3 months for 3 years. And that actually was approved based on a disease-free survival benefit, which is actually significant, but is also only for stage 3 disease. And you had to have, not microscopic stage 3. If you have microscopic lymph node mets, that is, those patients were excluded. And what's important in this study is that there was a 25% improvement in recurrence-free survival, and this was actually at 3-year follow-up. And so that is significant. For some physicians will think, well, there is no overall survival benefit, but that may actually translate in the future with more follow-ups with a better overall survival. So this is, I think, become standard treatment for the lymph node positive disease. The problem with this study is that it was compared to placebo, and I think had it been compared to the standard therapy, interferon would have had much more weight to it. There is an ECOG trial that was just completed, actually, looking at ipilimumab versus interferon, and the ipilimumab was the 3 milligram per kilo and the 10 milligram per kilo dose, and we can and that's a long-awaited trial, and we'll know whether this will change the standard of practice. So, NCCN guidelines is our Bible, and every year it grows and becomes more complicated, and you have to maneuver through it, and then this is the most updated one, and it's old. It's old as of couple 4 weeks, 3 or 4 weeks ago, and but that's kind of the Bible. It's nice to know what is recommended, and how do you treat. But I always say anybody can go to the NCCN and find out what to give. But the most important thing in our field is really to know how to manage the patients. In my opinion, I think toxicity and management of the patients is really much more important than efficacy, because you can only make efficacy worse by not recognizing how to manage the toxicities of these drugs. And trust me, these are so complicated in terms of management. So the way the treatment of melanoma is really, there's 3 different ways. There is the so-called oncogenic pathways in melanoma. These are newly discovered pathways, primarily protein kinases that are mutated or altered. And then the other pathway is the immune pathway, and then the third most recent pathway is the so-called oncolytic pathway, which we will touch on also. The oncogenic pathways is the first one that we will talk about. Don't be, intimidated by this cartoon, but this is not the whole thing. This is actually a simplified oncogenic pathway, and the different protein kinases that are involved. But simply put, there is the MAPK pathway, which is the mitogen activated protein kinase pathway, and so it's called MAPK. And that's these terms may sound familiar to you, the RAS, BRAF, MEK pathway, which we all have in our normal cells. And that is, mutated in some patients, especially BRAF, which turn out to be a good target for melanoma. RAS, for example, has not been shown to be a good target. And then the other pathway, which is the PI3K pathway, there's a lot of mutations and alterations, but as of yet, there is no drug therapy that is developed. I want to, the P53 pathway, by the way, which is down here, is also altered in many melanoma patients, but that has not translated into any therapy. There is the c-KIT pathway, which is everybody, or the c-KIT mutations, which is the the tyrosine kinase receptor at the membrane level, has been shown recently to be a good target, and it's mutated in 2% of the patients. It's worth checking for the c-KIT mutation, especially in patients with acral melanoma on their hands and their feet. And they have a higher risk, higher chance of having a c-KIT mutation, which would translate into giving them a tyrosine kinase inhibitor like imatinib. But the basis of the oncogenic pathway is the BRAF pathway. So this BRAF pathway, you can see on here, the normal is basically the RAS, BRAF, MEK pathway. It is involved in normal cell proliferation and survival. But if there is, a mutation in that BRAF pathway, this leads to a switch turned on, and there is increased proliferation and cell survival, and that is at the basis for malignancy for these patients, and it's present in up to 50% of patients with melanoma. And so naturally it would be to develop a drug that would actually inhibit this BRAF. And indeed, this is the first trial that was actually published, a phase 3 study that looked at what it used to be the standard chemotherapy in the old days, which we no longer use. Very rarely, actually, we use chemotherapy. And that looked at vemurafenib, which is the first BRAF inhibitor, compared to DTIC. And that looked at patients, with stage 3 and 3C or 4. We were actually involved with vemurafenib at the Zangmeister Center from its inception. We did the initial, phase 2 studies actually before this trial was published, and we were actually the only center in Ohio. We were getting patients from all over, Cleveland, Cincinnati, Dayton, and reportedly, this drug works so fast that literally you can see the disease shrink in front of your eyes. And I actually have witnessed that happens, because we used to bring these patients and give them the drug, and we have to do so many pharmacokinetic studies, and then by the end of the day, you can see so that they are actually responding. So the responses are very rapid, they're dramatic, and on this study was approved based on a PFS benefit, so there is a progression-free survival benefit, and in addition also there is an overall survival benefit. So the survival improvement is 63% improved. The hazard ratio is 0.37, so that has really changed the natural history of metastatic melanoma with BRAF inhibition. The other thing is that many different BRAF inhibitors do exist on the market. The next one is the dabrafenib, and dabrafenib provides the same inhibition of BRAF, and MEK has become also another target. So people said, okay, if I inhibit BRAF, then why don't I inhibit also MEK? And so combination therapy started coming up with dabrafenib and trametinib, and this is indeed the study was done comparing single agent to double agent, and therapy, and indeed that actually proved to be beneficial. So BRAF inhibition is very good, but also BRAF and MEK inhibition is better, and that showed a PFS benefit of 11 versus 8.8 month, and the overall survival is also better, and so that's the you may look at the curves and say, well, that's not too much improvement, but it's actually, if you look at the 2-year overall survival, there is nearly 10% more patients alive at 2 years. So 1 out of 10 patients, just because of the combination, are still alive because at 2 years, and that's significant in our world because before that we didn't have any survival improvement. So that has really become the new standard, and ever since this was published, uh, uh, and as of earlier this week, the drug called cobimetinib, it takes a while to learn how to pronounce these drugs, but cobimetinib is another MEK inhibitor, and that also was combined with vemurafenib, the initial BRAF inhibitor, and indeed that showed a survival improvement over vemurafenib, and that is the new standard now. You have to combine BRAF and MEK inhibition for those patients that are BRAF mutated. You can see the response rates down below, with 64% with the combination therapy and 68% here. So this is something really unheard of in the world of melanoma. We used to give chemotherapy in the old days, and if we get 5%, we're lucky. And so this is really a significant improvement, and the survival is significant. I personally have a number of patients. The most recent one of them is a 24-year-old girl who has metastatic melanoma, and actually presented that patient at tumor board, um, and she was on an immune therapy which she wasn't responding to, and when she switched to a BRAF MEK inhibitor, within 1 week she came back, because I was seeing her on a weekly basis. She was on oxygen and she was not doing well. Within 1 week she was off oxygen, and now 3 months later she's ready to go back to work. So this is this oncogenic pathway is a significant improvement. The other pathway that is very interesting and more complicated in my mind is this immune pathway. And this immune pathway in melanoma, we've always known that that's very important. We've always known that the immune system uh, has a great role since the days of the adoptive immune therapies, etc. And so recently we were able to discover that at the basis of this immune system is the T cell. And so T cells, the problem with melanoma is that they are not active. They're not activated. They're not really fighting the melanoma. So we used to take these T cells, try to multiply them and put them back in to try to. And as it turns out, the reasons why the T cells are not active is because there is these inhibitory receptors that are present on the T cells. The most recent ones discovered are the CTLA4 antibody, receptor, and then a PD-1 program death receptor on the T cells. And these basically send inhibitory signals to the T cell and prevent the T cell from being stimulated. On the other hand, and so there's all these others, and more are actually discovered every day. PD2, for example, now is discovered. And so these inhibitory receptors are inhibiting the T cell from being activated. And there is also activating receptors. So the way to stimulate the T cells is either by blocking antibodies for the inhibitory receptors, or by using agonistic antibodies to activate them even more. So the two receptors that we have available for us are basically the PD-1, the program death receptor, and then the CTLA4 receptor. This is a very simplified cartoon of how this works, but basically the cancer releases these antigens, and these antigens are presented by these antigen-presenting cells. like the macrophages, etc. And the T cell is supposed to basically attack these, but they are inhibited by the fact that PD-1 is sending a negative um, or an inhibitory signal to the T cell and not allowing it to attack these antigen-presenting cells and the tumor. And by blocking them with an anti-PD-1 antibody, or the anti-CTLA4 antibody would release this so-called checkpoint inhibition and would allow these T cells to attack the tumors. So basically, in other words, the way I explain it to my patients is that the cancer is evading, the tumor cells. I mean the T cells, and then we have to, do something to make the T cells wake up and realize that there is a foreign antibody present, um, or a foreign body present. And in terms of PD-1 inhibition, it turns out the ligand on the tumor is the PD-L1, so you can actually even do a PD-L1 antibody and then inhibit also make that reaction or that immune system wake up. So there is three drugs actually. The one CTLA4 antibody, which is ipilimumab. This table shows the response rates that actually led to the approval of these three drugs in the beginning. They were all approved based on response rates. And ipilimumab is the CTLA4 antibody and had a response rate of 11%. But some of those responders were long-term responders. Also, we were, involved at the Zangmeister Center with ipilimumab, and we were actually the only site in Ohio where we treated a number of patients with this drug. But it was a significant improvement because these patients had long-term duration, a long duration of response. As it turns out, in phase 3 studies afterwards, there was a survival benefit. The other two drugs are the PD-1 inhibitors, pembrolizumab and nivolumab, showed response rates that are higher, so they're really much more active than ipilimumab. These are response rates in the second line. So in the first line setting, actually, the numbers were better, and they were also better than ipilimumab. When pembrolizumab was compared to ipilimumab, the one-year survival rates were much better than ipilimumab, and the response rates were also much better, 34% versus 12%. In the so-called checkmate trial, where they combined nivolumab with ipilimumab, and the other arm of the study was nivolumab, and then the control was ipilimumab. These are first-line setting. 58% was the response rate with the combination, and 44% with nivolumab only. As a matter of fact, these drugs are now approved in combination, nivolumab with ipilimumab, in first-line treatment of malignant melanoma. So, and the survival was better. Pembrolizumab is indicated as a single agent in the first-line setting. So the last pathway, and I still have two more slides and I'm done. This is the newest pathway that was actually targeted. It's the so-called oncolytic viral immunotherapy pathway. It's a fancy term for basically injecting some viruses in tumors, and that's basically what it is. And the injection of these viruses in these tumors would actually lead to cell necrosis, and the cell necrosis will recruit the immune system and basically create a local response. So this is not a systemic therapy, this is a local therapy. And some of our patients actually have significant amount of disease on their skin or their lymph nodes that cannot be controlled. And these local injections can help control the local disease. And so the first one, and the only one so far approved, is the TVAC virus, which is actually a herpes simplex virus in monkeys. And I don't know who got the idea to bring that virus from the monkey and inject in uh, these patients, but indeed that was done, and it was a randomized study, and this drug is now FDA approved for local injections. And this was a randomized study injecting in the lymph node or in the skin lesions, and versus GM-CSF, which was the control. And they showed response rates that are durable, 16 versus 2%, and then the overall response rates were 26 versus 5%. So some of these patients achieved a CR, complete disappearance of their skin lesions, uh, and some had a PR. The challenge with this drug is, this is not something medical oncology can do. And the challenge is that you have to find physicians that are trained on how to inject these and the dose and etc. And this has actually really only been approved about 3 weeks ago as a so it is very early to tell how this drug will do. My suspicion is that first, there is not too many patients that are eligible, and my suspicion is that these patients, if they have systemic metastatic disease, that basically takes over, what's happening locally, and you won't find many patients that you want to really inject. It's going to be extremely rare. And probably by the time this one patient comes, there'll be another drug that is approved that you would want to use, or maybe another clinical trial that you want to put the patient on. So I don't think that oncolytic pathway has much of a future in terms of our treatment armamentarium. The other virus is the Coxsackie virus. This is a phase 2 study that was presented at ASCO and published in JCO most recently. And kind of the same thing. It's another virus you inject in the lesions. It gives you a response rate of 28%. As it turns out, really, this is not an innovative therapy. As a matter of fact, we have been injecting lesions for many, many years before. There's data with injecting lesions with interferon. There is data with injecting lesions with BCG, IL-2. And so, if you actually look at the NCCN guidelines, these recommendations do exist. The only difference is that interferon and BCG is much cheaper than injecting them with these fancy viruses. So that's another reason why I don't think that's a. So I think this is my last slide, but I want to say the last thing is, these are the activities. This is the efficacy. Yes, we can, prolong survival. Some of these patients, especially the immune therapy ones, have that long-term overall survival that is 5 years and longer. Some patients are considered, cured. You have to give a lot to the immune system and the immune therapies for those. But at the end of the day, really what's more important in our role as medical oncologists is to manage these patients and try to keep them on therapy. These toxicities can be life-threatening. One of the toxicities of ipilimumab, for example, is hypophysitis. They lose all their pituitary gland, so they have significant. They don't have any hormones anymore. So these are not simple drugs to give. Some of them cause autoimmune reactions that can be fatal, like liver autoimmune toxicity, etc. So they need to be. We need to manage them very closely so we can actually keep them on therapy and have that long-term benefit. So, yeah. Can anybody ask questions or no?
Do you want to save questions to the end, or we can do now, whatever you would prefer?
No, you can do questions at the end. I give some time to
Great.
Greg.
Thank you very much.
How you do that? All right. Thank you.
You know how to. Well, he's getting my slides.